78-year-old patient, long-standing uncontrolled diabetes, presented to me with acute coronary syndrome. The check angiogram of the LED shows a diffused fibrotic calcified critical stenosis throughout the length of the LED artery. This is an epicranial view to show the diffuse nature of the LED artery, and a 0.014 BMW wire is being advanced through the guide catheter and manipulated through the stenotic lesion and placed distally in the vessel. A 2.5 by 12 mini track balloon is now being advanced. Multiple inflations are being made in the LED artery. You can see the severe stenotic lesion with waste on the balloon which disappeared at high pressures to open up the lesion to 14 to 16 atmospheres. Here you see multiple balloon inflations throughout the length of the LED artery. This is a very diffusely diseased LED artery in a long-standing diabetic patient who has uncontrolled diabetes on insulin and oral hypoglycemic agents. Here the balloon has been placed proximally near the ostium of the LED. Again, a balloon dilatation is being made. This is at 14 atmospheres. A check angiogram is being made which shows the lesion opened up, but still you can look at the diffuse nature of the disease. This is a 2.5 by 38 mm biomime, which is a drug-eluting stent which is being advanced into the LED. You see how smoothly the biomime stent went from the proximal to the mid to the distal segment of the diffusely diseased LED artery. This is the positioning of the biomime stent in the LED artery. Biomime is a drug-eluting stent. It is a cobalt chromium stent. It has the drug which is from the sirolimus group. These are check angiograms being made to see the positioning of the biomime. The biomime is now being inflated at 12 to 14 atmospheres and being deployed in the distal and the mid segment of the LED artery. The balloon is pulled back. Now the balloon is being used both for sizing the proximal stent and for dilatation of the lesion. This is the stent balloon which is being used to dilate the lesion. These are multiple projections which are being shown. This is a 3 by 38 biomime stent which is being placed in the proximal segment, overlapping the distal biomime stent by 2 mm. This is the deployment of the biomime stent. The overlap is 2 struts, the proximal to the distal. The guiding catheter is an extra backup guiding catheter from Cordis. This is the injection after the stent deployment. A 3 by 20 mm Sprinter high pressure balloon is being used for the post dilatation. Multiple inflations are being made to post dilate the stent. Very important to post dilate the junction between the two stents because these are two 38 mm biomimes covering from proximal to the distal lesion of the diffusely diseased nature of the LED. The struts are to be well opposed on the arterial wall and hence a post dilatation at high pressures. This is basically to prevent the thrombosis and the restenosis and to oppose the stent well on the arterial wall. Just post dilating with a high pressure balloon is like a poor man's IVUS because most of the time you will be able to see the balloon deploying the stent well. This is the final result post dilatation, but you can see the diffuse nature of the disease in the LED, which is due to the long standing uncontrolled diabetes. This is the patient along with me. Seems happy. He was advised a bypass surgery, and here you can see the diffuse nature before and after the biomime multiple stent deployment. Looks like you've created a new artery. Thank you.